Thank you. Can I start? Yeah. Good morning, ladies and gentlemen. It gives me great pleasure to be in Gurugram, having studied in Delhi and being a graduate of Maulana Azad. So what I'm going to talk to you about is really managing unhappy complications in presbyopia intraocular lenses patients. And when do we get unhappy patients? We get unhappy patients when they're surprised, when they don't get what they're expecting. And it's all about, in presbyopia surgery, presbyopia lens surgery, it's a matter of optimization. It's a matter of using lenses to get as wide a focal range as we can with the least quality of vision quality of vision compromise. And hence, we tend to get two particular types of patients who are the reasons for being unhappy. You get patients with residual defocus and torus or refractive surprises, and you get patients who are neuroadaptation failures because they don't adapt well to the halos and glare that come with a lot of these. Inaccurate spherical targeting is a very common thing that can happen if your biometry systems are not up to date. This happens for a number of eyes, small eyes, lower tolerances. All presbyopia lenses, they have lower tolerances for defocus errors as such. And any defocus will make the glare and halos worse. Patient is then confused, is it the lens or is it the refractive error? And you can enhance these quite easily. Astigmatism is even more of a problem because the tolerance for astigmatism with multifocal or presbyopia lenses is even more critical, and it's much less. So we have to aim for getting patients to under half a diopter of cylinder post-op, and there are various ways we could do this, either by astigmatic keratotomies, LRIs, afterwards, or secondary toric piggyback lenses. And in very high levels of cells, I think it's important to talk to patients and say it'll be a two-stage bioptics procedure. What about contrast and halos? This is something that is part and parcel of presbyopia lenses because there is a trade-off, and then we expect the neuroadaptation process to improve on these symptoms. And before you actually do an intraocular lens exchange to get rid of patients who have insufferable glare and halos or contrast issues, it's important to talk to patients and show them what they will lose in terms of their reading ability in exchange for being better in terms of halos and glare. And it's quite amazing how many patients then at that stage feel, no, it's not worth it. There are standard expectations for our cataract patients, but patients who are seeking presbyopia lenses have very high expectations. They have obsessive personalities, and they have lower tolerances for accepting anything less than so-called perfect vision. And it's important to keep that in mind, that any surgical complication can have these. So how do we manage these problems? You have to define the problem. You have to target the refraction. You have to think in terms of the quality of vision, and you have to think in terms of the neuroadaptation. One has to be open and talk to the patients very clearly. You have to answer their questions very fully. You have to work with the patient and never ignore their complaints, because the moment you start patronizing the patient, it becomes very difficult to manage things further. So what about prevention? Before you start doing presbyopia lenses, in terms of understanding, how do you protect yourself? How do you set up your own systems before we can get into this? The first thing is to set very realistic expectations. It's very important for patients to know exactly what kind of vision they will get, and this has to be an open, frank, honest doctor-patient partnership. Patients invariably want spectacle independence, and the first thing I say to them is, no, you will never be spectacle independent, because there will always be certain situations and certain types of light and certain types of sizes of print that they will still need spectacles for fine near vision tasks, for example. So this is what I say to them. You will see well enough to legally drive a car without glasses. You'll be able to read most things in good light without glasses. I then go on to say to them, you will need spectacles for fine near vision tasks, and some patients prefer to use a pair of spectacles for night driving. So this gives a very clear idea as to what they expect. I then talk to them about the contrast. I then talk to them about the glare, halo, and starburst. And I say to them, and this is how I put to them, that you cannot get multifocality without getting these halos, because that's a law of physics. So when you see a halo after your surgery, think in terms of the lens is doing what it's designed to do, and hence it becomes a positive thing for the patient to look for. We know that with neuroadaptation, all these symptoms tend to improve, and there is good scientific evidence now to show that within 6 months, the functional MRI studies show that there is significant neuroadaptation in multifocal patients. Then we have the standard things that happen with any type of surgery. We have to talk to them about the certainty and the uncertainty, and we get these figures that less than 5% of patients will need an enhancement, and less than 1% end up with worse vision than what they have to begin with. A key area is your biometry targeting, and it's very important that you have to be as good as this gentleman here who's carrying bricks on his head. But it has to be that precise for us to get our presbyopia patients to good outcomes. So one has to be aware, one has to diagnose and treat dry eye or ocular surface disease. This is something which is very common. It catches quite a lot of people out. Especially before your biometry, it's important to get the surface right. During the surgery, it's important to get the surface right, because this is something which can increase the glare and the halos and the contrast, and it becomes very difficult then after surgery to then say, okay, you now have a dry eye, if initially you didn't tell the patient that. There is always an opportunity when you do the second eye to try and reduce any potential problems. So you could look at what is the issue that a patient is facing after the first eye, and you could choose what to do for the second eye. There's a whole number of reasons you can do this. There are ways you could use the same multifocal, a different multifocal, an EDOF lens, or you could choose a slightly different defocus using monofocals and monovision, or enhanced monofocals, or an EDOF lens. Whichever way we do this, the actual process in my practice is this. We do the first eye, and at the second eye, if the patient is happy with everything, we just repeat the same thing. If the patient wants even better near vision, so they're happy with their distance vision, they're happy with their glare and halos, then you either put in half a diopter or 1 diopter of myopia in the second eye, or you personalize it with a multifocal lens which has more near vision performance. If patients want even better distance vision, let's say the patient ends up half a diopter myopic, they're fantastic for near, but they want even better distance vision, then I would consider a monofocal in the second eye or an EDOF lens in the second eye. If the patient is happy with the near vision but struggles with halos and glare, and they're really concerned about the night driving, then after checking that they don't have any significant defocus or torus, we tend to then use a monofocal for the second eye. So really, by using these strategies, we can prevent our patients from getting unhappy, and if they do get unhappy and we get poor outcomes, we can get them to good results almost all the time. Thank you.
Thanks a lot, Dr. Pandey. My question to you is that which is your preferred IOL, presbyopic IOL?
There isn't my preferred IOL.
Okay.
It's a bit like asking a professional photographer, you will only use one lens for all types of photography.
Yeah.
It's impossible. So I think it's very important to customize each lens to each patient.
Okay.
And not just each patient, but each patient's eye. Because each lens will have a particular advantage and limitation. And how we use these in a combination to generate the binocular visual percept is the key to this. So I use trifocals, I use EDOFs, I use enhanced monofocals, I use monofocals, And we don't charge in my practice separately based on lenses.
Okay.
We have one price for everything, and we just say, we get you the best vision possible with everything that's possible on this planet.
Okay. Thanks a lot.
Thank you. Thank you.
Thank you. Good morning, everybody. My name is Dr. Aishwarya. I'm a consultant in Narayan Nethralaya, and today we are here with Dr.Hema Malini, who is the chief instructor. We come to you with a presentation of maximizing outcomes with Phakic Iols, a systematic approach to achieving perfect results. Our colleagues, Dr. Ravi Krishna and Dr. Lucy, will also be a part of this IC. So I begin with my topic, that is the patient, the history, and the workup of a Phakic IOL. Today I would like to take you to an algorithmic approach towards a Phakic IOL. As we all know that previously we were gifted with anterior chamber angle fixated IOLs, which was from Nuvita, Kelman, iCare, and Vivat. But as of now, none of us are using it, at least I hope so. And then came those iris supported Phakic IOLs. And after that came what we are normally using, that is IPCLs, ICLs, presbyopic IPCLs, which are new in market, and also from Biotech and Apasami, ICRIL Phakic lenses and refractive implantable lenses. What's important to note is that these lenses, although they look similar, but the best part is that they have different IOL ranges and IOL sizes. The first comes something which we use on a regular basis, although it's on the slightly pricier side, but this is one of the most acknowledged and very well working lenses, that is ICLs and TICLs, that is those toric lenses. Then comes this presbyopic IPCLDs and the IPCLDTs, that is the toric part. From -1 to -30, it's a huge range. That is what you have to kind of appreciate, the fact that practically no matter which patient comes to you, which cylinder comes to you, that is like up to almost plus 10 diopters, which comes in IPCLs, it's a huge range. So, and it is customizable as well. So in Phakic IOL sizes, in ICLs you have Phakic IOLs which range from 11.6 millimeter, 12.1, 12.6, 13.2 and 13.7. But in IPCLs, all the range starts from between 11 to 14 mm in 0.25 mm steps. So the sizing, which is actually the cornerstone in this particular surgery, is one of the main reasons that these ranges are available for you to pick and choose according to the patient that you have. Now, our textbook states certain indications, which is like 21 to 45 years of age, high myopia, stable reflection, less than 0.5 degree change in diopter change in 12 months, angle grades 3 to 4, that is von Herrichs, then no previous ophthalmic surgery, no previous ocular pathology like keratoconus, which is actually an off-label use currently, glaucoma, fuchs dystrophy, etc. The contraindications are further much more, but the main ones are bad cornea, that is poor endothelial cell count, zonal abnormalities, patients who are having ocular motility disorders, intermittent divergent squint, monocular patients, patients who are pregnant and lactating, diabetes mellitus, etc. And of course, the presence of trauma. Now let's see what actually happens in our clinic. In our patients, when we have a long list, you have to see like these patients, they say, I have worn glasses all my life, I do not want to wear more. Patient was told, you cannot undergo LASIK. Patient has not understood why. I can't tell my husband or fiance that I have glasses or I have power. I need to get rid of it. My friends make fun of me. All of us have undergone the trauma of sitting on the chair and listening to these things, but these things are very, very important. The patient and the history goes beyond just the age factor. It is like the patient is very, very particular. My looks matter. Getting married with glasses is not an option. I need to get rid of my glasses. Patient is highly confused with the Google history, and patient is often accompanied by a lot of people like parents, siblings, to-be significant others, friends, spouses. There's a lot of pressure on the patient. Patient comes with a big binder with previous consultation as well. These patients are social introverts and have low self-esteem. So there is an emotional and a psychological angle to all these patients as well, which need to be considered while we are talking and counseling to these patients. Now this is the workflow which we have over here in Narayan Nethralaya. Right from registration, ARR, NCT, refraction, we have two sorts of tests, that is before dilatation and after dilatation. So before dilatation, from slit lamp examination to counseling to pentagam, specular, OPSCAN, OPD, ASOCT, gonio, UBM, manual K1, K2, all these things come before the dilatation part. After the dilatation, we do macular OCT, retina opinion, dilated eye trace, pentagam, counseling, and then again counseling by the counselors. Now, ARR, NCT and refraction in our setup is done by either trained optometrist or a trained professional. So these people have been instructed that whenever you have patients who have come with high myopia, or they have high IOP, or they have scleral contact lens usage, or they have amblyopia, scissor reflex, or media opacity, please put it on the EMR that we are using. It's important for the surgeon to be informed about these things. Of course, if in your private practice this setup belongs to you, then you have to kind of make sure that you put it on the paper so that it reminds you of the red flags that you have to look forward to before you take the final decision. Now, the red flags in slit lamp and gonioscopy are many. The most important ones I would like to specify over here: central lenticular opacities, pupillary reaction, posterior synechiae, presence of rhoplast, the anterior chamber depth, again, angle recession or presence of trauma, the history of trauma, peripheral anterior synechiae, and peripheral and previous refractive procedures where there has been a failed LASIK or a surgery or post-refractive ectasia. All these things may not be remembered by the patient himself or herself, and the patient may not give you the history of these surgeries. Now comes the counseling part. Now this counseling is the first counseling, that is you have to set the expectations right, you have to tell them about the eligibility criterias, then you can inform them about the Phakic Iols. Of course, the surgical options also will have to be told to them, like LASIK and SMILE. Then you also have to answer their Google queries, that what all can go wrong with them. They have a lot of questions regarding that. But at the same time, you have to insist that please go through the algorithmic approach, then only we will be able to take a decision for you. And then again, you have to give the handover to the patient's counselor or a patient care coordinator who speaks the same language as you. Coming to the pentagam, the red flags over here again are irregular astigmatism. Keratoconus, again, we have been using ICLs and IPCLs for quite some time where we have been using it, but at the same time it remains an off-label use. Densitometry will help you to understand if at all there is any lenticular opacity which is present. Anterior chamber depth from pentagam is an important cornerstone of this surgery, which I'll discuss later. And then pachymetry, and look for the warping effect of previous contact lens. Coming to the specular, as we all know, any presence of guttae will not be appreciated at all. You will have to move forward to that. Then comes the eye trace, where you have to look at the DLI score or the score which will help you to understand if at all there is a presence of cataract over there. Then comes the OPD3 scan, where a 5 mm pupil, myopic pupil, is important to understand that the presence of a pupil which is more than 5 mm will create a problem in patients who are undergoing EVO+, where it will not work, as the maximum size is around 5.2 up to -14 diopters. You have to increase the presence of glare in such patients, and if the patient agrees for the surgery, take a special consent in written format. The patient knows that there could be glare in such patients. Coming to the op scan, white to white, this is what we use in our setup. Of course, many people do use calipers, but this is what we use over here. Anterior segment OCT is also important for us to determine the central ACD, the iris configurations and the angles. The UBM helps us to understand the sulcus to sulcus diameter, the presence of iris cysts, the ciliary body configuration, anterior chamber depth, and it also, this quantal UBM also helps us to understand whether we can put a particular sized ICL in the sulcus over there or not, if according to whatever the paper has been given to from the company, whatever calculation has happened. Manual keratometry is done by many doctors who want to find out whether all the machines are correlating or not. At this point of time, ACD will help us to understand OpScan, Pentacam, UBM, Galilei, Lenstar, ASOCT, all will give you ACDs, but you have to take your own decision based on whatever values you feel are going to be helpful for you to size the ICL or the IPCL. Dilatation, post-dilatation, we have to look for zonular laxity, phacodonesis, and retinal evaluation is a must. In retinal evaluation, a very normal looking retina can be harboring something like solar retinopathy, macular telangiectasia, achromatopsia, or vitreomacular traction. Retinal opinion will also help you to understand whether there is any lattice regeneration, retinal breaks, peripheral retinal detachment, and you need to treat them before you proceed. Eye trace, dilated eye trace and dilated pentacam will help you to understand certain higher order aberrations which are not present before dilatation. So that's also important. Now the final counseling, which actually takes a maximum chair time. You need to take all the readings into account before you give the final seal of approval. Explain the pre-operative, intraoperative and post-operative care yourself. We need to set the expectations right. We need to undercommit and over-deliver. Discuss the pros and cons with the help of your consent form. The customization has to be discussed at this point of time. Please always keep room for error and the chance that the IOL could be exchanged over there. Do not rule out future surgeries in view of cataract. And the insurance aspect, because a lot of patients who are coming to us, they come with insurance packages and they need to be told that your insurance will not cover this particular surgery as it is an elective surgery. And this is our pre-op checklist which we use just before the surgery. The person who's undergoing the surgery will have all these things ready in front of the surgeon. The surgeon will take a look at all these points like specular microscopy, WTW, any corneal procedures. Everything has to be, that everything is perfect, then only the surgery has to be proceeded with. Last but not the least, I'd like to talk about the informed consent. We have a 4-sided informed consent. It goes from the introduction of the surgeries to high myopia and then the surgical alternatives present. It talks about the general description of phakic IOL surgeries, and then the patient also has to consent about the vision threatening complications and the non-vision threatening complications. And after that, there is a certain section which talks about that the patient is willing to undergo the surgery after understanding all these points as well. So here I end my talk. I would now hand over the mic to Dr. Hema Malini, who will talk about her topic over here.
Very good morning to all of you all. So my topic is, my first talk is on sizing of phakic lenses. No, there has to be one more presentation. Shall I start with the second one? This is my second talk actually. I guess I'll do the first one once the presentation is uploaded. So this is about sizing abnormalities of phakic lenses. To be more specific, ICLs, since they are the most popularly used posterior chamber phakic lenses. So basically, sizing abnormalities would result in either a high vault or a low vault of the lens. So what exactly is the vault? Vault is defined as the distance between where the ICL is placed, that is the posterior surface of this ICL, and the anterior surface of the crystalline lens. So generally, there is a safe distance that has to be maintained between these two structures, ensuring long-term safety and efficacy. So what is this safe? Is there a particular number or a safe vault that has to be maintained once the ICL implantation is done? So a truly ideal vault means it should be around 500 microns. So any vault that is probably less than 90 microns can be considered as a low vault. So a vault which is below this 90 micron gives rise to cataract formation. And any vault that is more than 1000 microns, as quoted by the studies done by Choi et al., results in angle closure and pigment dispersion glaucomas. So it's nearly impossible for us to get an ideal vault of 500 microns all the time. Therefore, a good range would be between 250 to 750 microns. And if you stretch the limits a little bit more, maybe 90 to 1000 microns. So how do you grade this vault? On slit lamp, you can qualitatively grade this vault by comparing the slit beam width, that is between the ICL and the crystalline lens, as against the corneal thickness. So a normal corneal thickness is taken as about 500 microns. So you give a grading of 1 if it is about 500 microns, 1 corneal thickness, or half corneal thickness is if it's about 250 microns, so on and so forth. So you can also quantitatively measure this vault. You can do this either on the UBM or on the ASOCT. So what are the effects of these abnormal vaults? Like I said before, high vaults, which are anything above 1000 microns, would lead to angle closure, pigment dispersion, glaucomas. And vaults which are less than 90 microns can give rise to instability of the lens per se, and if it's a toric lens, it can cause decentration, and astigmatism can further worsen, or it can lead to cataractogenesis. So first let's look at oversized ICL in a small eye that would give rise to a high vault. So what exactly happens in a case of high vault? Due to the excessive vaulting because of the larger lens that has been implanted, the iris diaphragm bulges forward. And then with this bulging forward of the iris diaphragm, there is narrowing of the iridocorneal angle. There could be chafing of the posterior pigmented iris leading to pigment dispersion. And then there would be also a subsequent risk of angle closure leading to peripheral anterior synechiae and angle closure glaucoma. Also, it could lead to pigmentary glaucoma. So the commonest symptom that the patient would present with would be ocular pain and tenderness. Basically, this arises because of the nerve irritation due to excessive pressure in the ciliary sulcus. Well, there have been several studies that have been done assessing vault and high vault consequences. So amongst the notable studies here, you can see in 3 years follow-up in the study done by Kamiya et al., there was no pigment dispersion or pupillary block. And in the study done by Igarashi et al., there were amongst 41 eyes with an 8-year follow-up, 1.7% had the risk of a high vault. So let us look at a case scenario in a patient who underwent bilateral ICL implantations and had to undergo an ICL exchange. So this is the pre-op data. This is the OBSCAN white to white values in the right and the left eye. It is pretty much same, about 11.8. And this is the pre-op specular microscopy of the right and left eyes. And we compulsorily do a pre-operative UBM for all patients who are planned for ICL implantations to get the sulcus to sulcus values, as that is the site where the ICL is going to be implanted. So these are the right eye and left eye STS values. And this is the calculation sheet which gave us a size of 13.2 both in the right as well as the left eye. So the patient underwent the ICL implantation in the left eye first as per the calculated size of 13.2 millimeters, and there was a surprise. Post-operatively, high vault was noted. Although the IOP was normal, gonioscopy showed almost 360 degrees closed angles. So this is the AIOC image. You can see here the vault is abnormally high. It is about 1.318 or 1318 microns, which is high. So coming to the summary of events, in view of the high vault with a 13.2 lens that was implanted, in the second eye we went ahead, sized the ICL, undersized the ICL to one size smaller and implanted a 12.6 instead of a 13.2, and post-operatively the patient had a good vault. So there is no overemphasis when I say STS calculation on the UBM minimizes these vault complications. So this is the right eye wherein the size was undersized, and the patient had a good vault of 430 microns. So this is a small video showing the ICL exchange in case of a high vault. So once the pre-op marking is done for the exchanged ICL to be implanted, the pre-existing ICL that is already there is gently manipulated into the anterior chamber and explanted. We can either use the ICL loading forceps or a McPherson to remove the ICL. It comes out in toto easily through the incision itself. So this is next followed by a routine phaco, and in this case a trifocal lens was implanted. So how to manage a case of high vault? So any high vault that is noted, say which is more than 1000 microns, first assess the central anterior chamber depth as well as the peripheral anterior chamber depth. If it is extremely shallow and you're seeing an obvious iridocorneal touch, then you need to plan for an ICL exchange. Next, you assess the pupil size and reaction. Also look for near vision. It is an important clue. So generally in the presence of a high vault, the pupil is extremely large, fails to react normally, and patients first complain of inability to see near clearly. So assess this, and in case of a large pupil or a defective near vision also, one needs to consider an ICL exchange. Next, measure the IOP. If it's on the higher side, persistently high despite AGM. Along with that, you do a gonioscopy and you find that the angles are closed, or there is heavy pigment dispersion, or there is a PAS formation, also then plan for an ICL exchange. Look for the ICL footplate position either on the UBM or AIOCT, and if it's mal-positioned, you can always reposition it in the vertical meridian, but this works only for a spherical ICL. Despite this, if it is still high, then you need to plan for an ICL exchange. Let us now look at the next scenario, which is a low vault. In case of a low vault, there would be a mid-peripheral ICL and lens touch, or there could be all along both in the central as well as peripheral ICL touch. So these are slit lamp photographs showing anterior subcapsular opacities with the ICL in situ. And what exactly is a low vault? Here it's an example, it's about 136 microns. There have been several studies studying crystalline lens opacity formation following an ICL implantation. Also, the other complication of low vault is rotational instability. So there have been studies stating that the rotation stability of ICLs is quite good. So what are the factors that would induce cataract formation post ICL? Let us look at the patient dependent factors. So first would be the age. So older the age of the patient at the time of implantation, higher would be the chance of cataract. Also, history of trauma. You should also look for pre-existing opacities even before you plan your ICL implantation. Also, in case of higher refractive state, higher myopia have a greater chance of cataract. What are the intraocular lens dependent factors? One would be the overall length and design, as we obviously know, and vault height also determines. So initially, if you have a vault of more than 550 microns, with time the vault is known to decrease. So in 10 years time, there would be decreased risk of cataract formation, because to begin with the vault was quite good. So what is the mechanism of cataract formation? Here, first cause would be constant friction between the phakic lens and the anterior lens capsule, or there would be continuous disruption of the blood aqueous barrier, which is caused by friction between the iris and the ICL, basically because the ICL is fixated in the ciliary sulcus. And the third is metabolic or nutritional disturbance of the crystalline lens. Also, documenting these lens changes over a period of time is extremely important, and what better than a slit lamp photograph. So here you can see one example of a patient who was followed up with initial lens opacities way back in 2014 with serial documentation up to 2018, when these opacities became clinically and visually significant. Also, pentacam is another modality which can record progression of these lens opacities on the pentacam nucleus staging or the PNS. So what are the indications when you need to explant these ICLs? So over a period of periodic follow-up, if you see there is progression in the lens opacities, progressive drop in the best corrected visual acuity, if the patient has severe dysphotopsias, if the opacities are in the visual axis, or if there is progressive nuclear sclerosis inducing a myopic shift in refraction. So these are obvious indications for removal of the ICL followed up with a cataract surgery and IOL implantation. So preoperatively for all these patients, the parameters that one would need to carefully document would be the vision, dilated slit lamp examination, gonioscopy, obviously a thorough retinal evaluation, and specular microscopy is extremely important in these patients because they've already undergone an ICL implantation, and with time the specular counts also would have got altered. And the biometry of course is important here. Normally whenever there is another IOL inside the eye, the formula that is used for biometry or bilensectomy would be the correct axial length measurements would be based on the axial length along with the correction factor. But here the correction factor for ICL is extremely less. It's about 0.11 only. Therefore you need not have to make any specific changes in the axial length measurements. The IOL formulae that are reliable in these cases would be either a Barrett's or SRKT. So this is another video which shows ICL explantation followed with phaco and trifocal lens implantation. So what are the take-home points? One would be the cutoff values for low vault. Any vault less than 90 microns, one needs to be prepared to explant the ICL. And whenever you see a mid-peripheral ICL lens touch, or you have a low vault with recurrent toric ICL rotation, or you have documented progression of the lens opacities, and age of the patient of course, and increasing nuclear sclerosis. Thank you. Next speaker would be Dr. Ravi Krishna.
Good morning everybody. So I'll be talking about intraoperative pulse when you are doing ICLs, like do's and don'ts. So loading of the ICL, it can be a spherical ICL or toric ICL. So everybody thinks that this is one of the most difficult part in ICL surgery. So the star company people have given the injectors, two types of injector, either it is MSI PF or MSI TF, and there's a cartridge which is called SFC45 which requires incision of around 3 to 3.2, It's better not to do with 2.8 because wound assisted technique can lead to reversal of this ICL inside the wound. So this is the forceps which we use for loading the ICL. So basically the tip of this is large and it is angulated, which will not damage the lens. If you use other forceps, it can damage the either foot plate or the central optic. And this ICL, the packet comes with this foam tip plunger, which is usually dehydrated and compressed. That should be hydrated prior to the use. Otherwise, this ICL can get stuck between the cartridge and the tip. So what we can do is we can remove this the ICL from the bottle using this foam tip plunger. This is the cartridge which has a flat loading dock and the edges. First we have to use the BSS to activate the cartridge coating. Then we can use the visco. Basically HPMC is better to avoid other form of viscoelastic agent. So this is how the ICL looks inside that bottle, which is there in the BSS. So this is the identification mark. So right upper will have a hole and left lower will have a hole. So like this you are supposed to identify the ICL. Then we can use that plunger, foam tip plunger to slide the ICL to the tip of the bottle, opening of the bottle. Then with the same foam tip we can load it on to the cartridge. And after putting inside the cartridge, we are supposed to identify the marks like right upper hole and left lower hole to know the orientation. And usually it will be convex. When you keep it in this position, it will be convex upwards. After that, once we place the ICL into the cartridge, then use this forceps, and from the cartridge tip we are supposed to enter, and we are supposed to hold the ICL, and we are supposed to pull the cartridge, not the forceps, because sometimes it might tear the ICL. So after pulling inside the cartridge, we are supposed to look at the lens whether the 3 holes, one in the on the optic and other 2 will be on the haptic, are in the same line or not. And the lens should be pulled with like we should see the complete folded lens inside the tip of the cartridge. Then the same the foam tip plunger has to be introduced into the injector. Once it is locked, then we can use the cartridge and fix it into the loading system. This is how it looks. So once it is inside, then we are supposed to see the orientation of the ICL inside the cartridge. So sometimes it looks like a crumbled appearance, which says that it's poorly loaded ICL. If it is straight and smooth, then it means that it's properly loaded ICL. After finishing this step, we are supposed to keep this in the BSS solution. So this is the ICL loading video. So first we are supposed to fill the cartridge with the BSS, then visco, and do not overfill the cartridge with the visco because it will be difficult for you to load the lens. Then with the foam tip plunger we can remove the ICL from the bottle and place it over the cartridge. With the same foam tip we can push the other edge of the lens inside the cartridge. So this ICL into the cartridge. Some people use the forceps also, non-tooth forceps, and better not to touch the optic. if you have overfilled the cartridge with the IC visco, then it is very difficult for you to push the ICL into that cartridge space. Make sure that entire lens is inside that loading deck. Then use the forceps to hold the plate, not the optic. This is how you are supposed to introduce that. And catch hold, then slowly you are supposed to pull your left hand, not the right hand. Cartridge you are supposed to pull, don't try to pull the ICL with the forceps. Then just have a look at the lens, whether it is straight and smooth or like wrinkled appearance. Then the ICL surgery per se, it's very easy. People who have done cataract surgery, it's one of the easiest method. So there in cataract surgery you will be removing the crystalline lens, but here you are supposed to preserve the crystalline lens. So you are supposed to take a measures in which you should not damage this crystalline lens. So surgical technique involves 2 paracentesis, then visco injection, then temporal clear corneal incision, or else some people prefer to do superior, depends on the astigmatism, and then injection of ICL, then injection of visco on the ICL, then positioning of the ICL posterior to the iris, then removal of viscoelastic. These are the steps involved in ICL implantation. So you are not supposed to touch the central lens like natural lens. None of the parts should be touched with any of these instruments which we use when we are implanting the ICL. So this is 2 paracentesis which can be done 90° apart, or people like some people do at 60°. So one at 60 and other one at 90. So it depends on your comfortability. The paracentesis. (0-180). Then HPMC, we are supposed to inject, not other visco like sodium hyaluronate and all. And you should not overfill the chamber. If you overfill the chamber, people will become much more dilated and you will have little difficulty in putting the ICL behind the iris. This is how we are supposed to inject the visco. You can see that waves forming. This should be the end stage. You are not supposed to overfill. Then temporal clear corneal. So all cataract surgeons, they know how to create this temporal clear corneal incision. So it's better to do either 3 or 3.2, not to meddle with 2.8, not to do wound assisted technique which we usually do with Iols. And should be slow and very controlled entry, and the blade should be very sharp. And don't try to do this incision with a blunt blade, because in case if you go and hit the lens, then cataract will form and you will not be able to place the ICL. You may have to do the cataract surgery later. And the ICL injection is very, very important. So here place the cartridge inside the wound, not at the outer lip. The entire cartridge has to go inside, or else at least the edge should be near the inner lip of the wound. And inject slowly until the leading right landmark is visible. So if you push it fast, it might rotate and it might become reverse. Then you may have to pull the lens out and once again you have to reload. So slowly you inject and see to it that the hole on the right side, right upper side you are seeing. Once you see that hole, then start pushing little fast. Then it unfolds in that same manner. If you push it fast, it might open fast or else it might turn. So that's why here in ICL, the injection should be very, very slow. So in case if it becomes reverse, then Dr. Hema showed you one video just now. So you can pull that one of the foot plate outside the wound and you can slowly pull it. You don't have to extend the incision. It's very soft lens, it comes very easily. So this is how you are supposed to, this is the leading right upper mark. So once you start seeing that, there is a hole here, and slowly inject and it slowly opens. So one more hole is here, right upper and left lower. After injecting this ICL inside the eye, put the visco on the top of the ICL. Don't put the visco below the ICL. It will be difficult for you to wash later. So then you are supposed to put the foot plates behind the iris. So put the viscoelastic, then take the manipulator. Usually ICL star people, they give one manipulator. With that you can just first the distal one you are supposed to put, then the proximal, which is near the main wound. It's better to use the side port rather than main port to put these haptics below the iris. And do not touch the central optic part, and do not cross over the pupillary zone. For example, you are on the right side and you want to do something on the left side, better to go from the left side port rather than going from the right side port. So this is what you are not supposed to cross the pupil with the manipulator. So these are all the ICL positioning instruments. And once you position the ICL, if it is a toric one, you are supposed to rotate the ICL depending on the axis provided. Like usually it will be plus or minus 22 degree from 0. So just rotate. Then viscoelastic removal is very, very important to prevent the post-operative IOP rise. So once the ICL is positioned, then remove the visco. The same thing like toric, you can take a marker and mark, then align those lines which are there on the ICL in that axis. So this is the perfectly centered ICL. I'll just the same, the entire surgery in one video. Let's skip this. Thank you.
So this is actually my first talk. Sorry for the confusion. This is regarding the sizing of phakic lenses. So before we go into detail about the sizing part of it, what are the few important points that we need to remember? First, we need to realize that most of these phakic lenses come in fixed sizes. So we are dealing with fixed lenses versus varying anatomical range of the ciliary sulcus, which can be different for different individuals. And then we all know the ciliary sulcus is inaccessible to direct visualization, and therefore accurate measurement of the parameters is almost impossible. Also, the ciliary sulcus is a circular space, and its dimension is not uniform in all the 360 degrees. It's larger in the horizontal meridian than in the vertical meridian. And as we all know, most of the posterior chamber lenses that are currently there in the market use wide to wide as the measurement diameter for calculating the size. So this I already spoke about. So when you look at the landmark studies, the most notable was the US FDA trial, wherein they studied almost 526 patients. So when you look at the rate of surgical interventions in the number of patients, about 526, it was about 3.1%, which was the surgical interventions were either in the form of ICL repositioning, or it was either in the form of replacement, removal, etc. So like I said, what exactly do we know about the sulcus? So relative to the limbus, the sulcus is on an average about 0.21 millimeter more on either side, which makes it about 0.42 millimeters longer than the white to white measurement. So here itself we know that the measurements of white to white and STS will not really correlate at all. So there have been several studies studying the anatomy of the ciliary sulcus. And the landmark study, which was done by Werner and Isaac et al., this was way back in 2004, studying the ciliary sulcus and its relevance to ICL implantation. They found that there was a poor correlation between white to white and STS, more so in the 3 to 9 o'clock meridian. So these are few photographs from the same study, which actually shows the comparison of, in the first diagram you can show the red dotted line is the white to white measurement, and the blue dotted line is the sulcus to sulcus, and the second one is the Miyake apple view of the ciliary sulcus. So the only possible way how we can actually measure the ciliary sulcus is through the UBM. So what are the preoperative measurements that one needs for any posterior chamber lens implantation, phakic lens implantation? These would be the anterior chamber depth, the white to white measurements, the angle to angle, these are optional, the crystalline lens rise, the sulcus to sulcus distance, and obviously the most important being the endothelial cell counts. So the FDA study recommends the following parameters would be suitable for ICL implantations. If you see on the left hand side in the table, any white to white less than 10.5 patient would not be suitable, and anything more than 13 the ICL would not be recommended. So generally the rule of thumb is for all myopic implants, to the measured white to white value 0.5 to 1 mm is added, and for hyperopic lenses it is taken per se or 0.5 is deducted. So let us look at as such measurement of the anterior chamber depth. So what are the other parameters while measuring the anterior chamber depth that one needs to give importance to? One would be the angles, of course, and then make sure that the measurement values are taken from the endothelium and doesn't include the central corneal thickness, which many machines by default would have set it. So make sure before you read the anterior chamber depth values, the value is taken from the endothelium and not includes the entire corneal thickness. Also make sure that the machine is properly calibrated and a trained technician does it all the time, because your entire yes or no to do an ICL implantation essentially depends on the anterior chamber depth. Also look for contralateral eye discrepancies, in the sense if your right and left ACD values don't match, then it's actually a red flag. You need to pay more attention to that. And yes, the important thing here is we need to remember that there is very less space for you to maneuver inside a phakic eye when you do an ICL implantation, and essentially the crux of this would depend on your anterior chamber depth. So the various machines that would give us anterior chamber depth would be either ultrasound A scan or an optical A scan, Iol Master or Lenstar, OBSCAN, the ASOCT, Pentacam, and the UVM. So all have shown reasonable inter-device agreement in comparative studies. So next, coming to the white to white measurements, and this can be done manually using millimeter rules, either using the digital or surgical calipers or measurement gauges. And the popular one, the way how white to white is normally measured, is the automated version, which either can be done on the OBSCAN, IOL Master, Galilei, Pentacam, or the Lenstar. So few pearls on how the white to white is measured using the digital or surgical calipers. These measurements using calipers have to be done under the microscope with the patient in the supine position, and the eye is pre-treated with topical anesthetic, and make sure that the calipers are well calibrated, and make sure you take an average of at least 3 readings, and with the same anatomical landmarks that you would have initially identified with. So next would be the automated measurements of white to white. On the OB scan, you have the option of measuring it automated, and when you feel the automated measurements are not really very reliable, you can go to the Iometrics tool also. And we need to remember white to white values on other instruments compared to the OB scan can either overestimate or underestimate the white to white. The company also recommends using OB scan values. So this is the white to white measurement shown on the OB scan. And like I said, the Iometrics tool will help us to manually delineate the limbus, mark the limbus out, and then using the calipers, manually measure the white to white. So this situation may arise when you have different set of white to white values, when you measure it say 2 to 3 times, and you're confused as to what would be the white to white value that you need to take for ICL implantation. So to summarize regarding the white to white, the values provided by OBSCAN has been proven as reliable in most of the implantations. IOL Master slightly overestimates the value, and other white to white measurements have not been validated yet. So this is a prototype of the calculation sheet on the left hand side, wherein the various parameters have to be filled in, and on the right hand side you see the implantation orientation diagram, which will exactly tell us how the ICL needs to be aligned. This is in case of a toric ICL. So further, when you go to the online calculating and ordering system, OCOS for short, you also have a column wherein you can actually change the size that has been recommended after the calculation. So also you have a column for the cylindrical paths. You can actually choose a different cylindrical path to ensure that the residual cylindrical power and the spherical equivalent is on the lesser side. So coming to the next set of measurements, that is the sulcus to sulcus measurements using the UBM. So several studies have time and again proven that there is no correlation between white to white and ciliary sulcus diameter measurements, and white to white diameter is larger than the ciliary sulcus diameter, and most of the studies have also said that UBM is far more superior in determining the ICL length accurately compared to the conventional methods. So UBM, with the current generation UBM and the advanced newer UBMs, measuring STS is far more reliable and predictable, and it helps in precise ICL sizing. There have been several studies. Noteworthy among them is the study by Doherty et al., who came out with a nomogram using UBM for ICL sizing, and instead of the white to white values, they use the sulcus to sulcus measurements. There have been other studies too. Let us look at the newer generation UBMs. The Compact Touch STS UBM by Quantel Medical gives automated 10 measurements. Along with the STS measurements, it also gives us ACD and lens curvature measurements also. So here the machine has a pre-fed set of parameters that have to be aligned along with the probe for us to get accurate measurements. So this is how the machine gives automated 10 values with a standard deviation of 0.1. This also has a unique software that helps us in predicting the ICL vault. So if we have calculated a particular ICL size preoperatively using the white to white, we can always use the predictor software on the Compact Touch UBM to get what would be the approximate vault postoperatively. So this is especially useful in situations where you have discrepancies in the right and left eye values, or when you have borderline ACDs, or you have ended up with a high or low vault in one eye and you're yet to plan the second eye, or whenever you find there is a large discrepancy in the STS and white to white values. So this is one other newer generation UBM. Like I said, Doherty et al. Came out with a nomogram based on this UBM STS values. So they also concluded that UBM STS measurements are far superior compared to the white to white, and this should become the standard of care for ICL size selection. Now let us look at the next set of measurements, the angle-to-angle measurements, which can be done using the ASOCT. And amongst the various ASOCT machines that are currently available, Cassia 2 actually gives us automated values of angle to angle, which is nothing but the distance between the nasal and temporal angle recesses, the anterior chamber width, which is the distance between the scleral spurs, the lens vault, and the crystalline lens rise. So based on these parameters, the NK formula was developed by Nakamura, Kojima et al., Japanese ophthalmologists who came out with this formula, determined the ICL size using the parameters like the anterior chamber width, the angle to angle, and the crystalline lens rise. And they concluded that the sizing improved by more than 70% when using this proposed formula. So this is a comparison showing UBM versus ASOCT. ASOCT is more easy to operate it, and it's not examiner dependent, and it gives us automated, non-invasive, rapid assessment of values. So now let us look at a few examples how to choose the right size. So say, for example, you have a patient with 3 different white to white values, and you have differing values on repeating at different visits, or you find that the lens star white to white or the Iol master white to white do not correlate with your OBSCAN values. What do you do? So this is such an example where you see varying values of white to white between the right and left eye on the OBSCAN, calipers, lens star, and the NIDEC OPD3. So these are the right and left eye values on OBSCAN and the lens star biometry values. And STS, when you actually measured it on the, when we actually measured it on the UBM, showed almost same values between the right and left eye. So when faced with such a situation, the tips would be plan the eye with the smaller white to white if right and left eye have different values. Check the vault post-operatively, then size the other eye accordingly. Also, it's extremely rare for one to have different values of white to white between 2 eyes of the same patient. So it's always better to repeat the OBSCAN on another day. So the second example is when you have borderline ACD. The recommended would be 3 mm or maybe 2.9 to 2.8, but anything less than that is always not a good idea to plan an ICL implantation. So what do you do in these kind of cases? Here is an example where the right eye ACD was 2.6, left eye ACD was 2.6, and same thing on the OBSCAN also. ASOCT also was correlating with the lower ACD value. So what do you do? So it's extremely difficult to take a decision in these kind of patients. We always have to weigh the risks versus benefits, and I guess when a person is initially beginning to do ICLs, the immediate answer would be to not go in for an ICL implantations if the ACD is extremely low, or if the patient is highly motivated and forms some form of surgical correction to plan a refractive lens exchange. So versus if you still want to proceed with an ICL, probably in the hands of an experienced surgeon, these are the parameters that you need to carefully watch out for. Evaluate the angles, assess and reassess the corneal endothelium, look at the lens thickness, age of the patient, and then take a call whether you want to actually proceed. So this is to sum up the various ICL sizing methods. The white to white using the calipers or topography is simple, inexpensive, easy to measure, but it just gives us a surrogate anatomical landmark measurement. Sulcus to sulcus gives us direct measurements. Angle to angle, once again, is easy to obtain values, but this is also a surrogate anatomical landmark. Therefore, to summarize, Packer et al. Has done this paper on meta-analysis regarding the safety and of the central port design of the ICLs, and this is a beautiful way of summarizing it. All sizing methods work equally well. So if you actually look at it, the variations in vault are not related to the sizing methods. So a large range of vault is still well tolerated, and adverse events related to vaults occur at really very low rates. Thank you. So the next speaker would be Dr. Lucy.
Good afternoon, everyone. I am Dr. Lucy Kaveri. I work in Narayana Nethralaya, Bangalore. So my topic is short and long-term follow-up of patients, relevance of various investigations. With an extensive overview of pre-operative workup, how to do these meticulous calculations, most of my talk is already covered because whatever you do pre-op is something that you would be monitoring post-op to avoid these parameters. So when I joined my fellowship, I discussed it with one of our seniors after looking at their ICL post-op and extremely good results, that what should be my investigations once the patient has been done and the 6/6 has been achieved. The answer was very simple, that if your vault and IOP is okay post-operatively, you just forget about it. And that's the thing. With what extensive workup Dr. Hema Malini and Dr. Aishwarya has shown you, if you have done your homework prior to the surgery, you can forget about the patient. Patient will be happy as long as the cataract, natural cataract develops. But still, to go ahead, what exactly is short-term follow-up? Now, this definition varies for different people. For some, short-term would be say a week, 10 days, a month after the surgery, or for some it would be 6 months after the surgery, because ICL surgery, when done in early 20s, would be giving patient at least 20-25 years of spectacle-free life. So long-term follow-up again is till the time patient develops presbyopia or age-related cataract. Now looking in short-term follow-up, once the patient has been operated, in the immediate post-operative period, what all parameters should be looking into. The first and the earliest key to any abnormality is the visual acuity. Visual acuity on the first day post-op would let you know whether there was any too much of surgical manipulation, and if that was the case, it would something which would settle down easy. It would also let you know if there is high intraocular pressure. In cases of toric phakic Iols, whether there is any rotation, undercorrection or overcorrection done. Next to this is a good slit lamp evaluation, which will help you determine any of the earlier suspicion that visual acuity had arisen. On slit lamp evaluation also, if there is epithelial edema, then the next thing that you would suspect would be high intraocular pressure. This intraocular pressure in the immediate postoperative period could be because of the retained viscoelastic and inadequate wash after implanting the ICL, but it could also be a reason of it could also be due to high postoperative vault, which Dr. Hema Malini had shown earlier, and known that in the immediate postoperative period, if the vault is very high with ACD less, then it is one of the indicator to exchange the ICL, go back and see where your calculation went wrong, whether there was any sizing issue, and if it is due to sizing issue, then probably doing an early ICL exchange is the key. Similar would be the thing for a very low vault, because in long-term follow-up, this would lead to cataract as we saw earlier. And the next important assessment, the investigation that has to be done, is probably the vault assessment. With the current generation, there are plethora of devices available. It could be either anterior segment OCT, or it could be one of the topographers which are based on Scheimpflug or OCT based topographers, which would give you which would give you an objective value of the vault. However, slit lamp assessment still holds truth as the best one to evaluate vault. These investigations need to be followed up for the long term, because we saw that when the vault over time it decreases. Some people have said that it continues to decrease over 3 months of time, and couple of studies have said that it continues to decrease over 6 months of time. So most cases where the vault is borderline high with a good anterior chamber depth, we tend to leave the patient assuming that over next 3 months or 6 months the vault would come down. But that doesn't happen all the time. Even with the modern ICLs or IPCLs, where there is a central hole or peripheral hole available, if you leave this high vault for longer duration of time without assessing the angle, there are chances of angle closure happening. So this was one case done with IPCL, where despite the fact that 6 holes were present, patient developed angle closure, and in the lower image you can see after doing the PI, the vault had come down. Other than angle closure, the most common type of glaucoma in the immediate period is the steroid responsive glaucoma or pupillary block glaucoma, and there have been multiple case reports of pigment dispersion glaucoma, either due to manipulation of the surgery where the pigment dispersion is lot more, or general tendency of high myopic patients to go ahead with pigment dispersion. Hence, gonioscopy in your follow-up period becomes one of the important investigation. Despite so many advances and newer models of phakic IOLs coming in picture, the vision outcome has improved, but the recent report says surgeons are still afraid of the cataract formation, because once that is developed, the patient loses the natural crystalline lens which is there. So there have been multiple meta-analysis, and Dr. Hema has already covered the pathogenesis of how cataract develops. But then why to wait for such a stage where the cataract is already developed? When you are doing a cosmetic surgery, it is a good idea to document the patient's density, lens densitometry, from the pre-operative period and each follow-up visit, so that when the lens density changes are beginning, you can counsel and educate the patient regarding the same. So in order to document these density changes, there's a tool available on Pentacam where, based on Scheimpflug densitometry, it also gives you the Pentacam nuclear staging, where it determines stages from 1 to 5, where 1 would be the earliest density changes. You can also move the cursor to each level of the lens to see where exactly the density is increasing. One more new tool is available with Tracy Surgicals, where it gives you the dysfunctional lens index. Now this dysfunctional lens index is a combination of internal aberration, lens density changes, and pupil size measurement. So even not just for lens density changes, it is also useful as a follow-up tool for ICL patients where they complain of loss of contrast sensitivity or glare or halos, where you can get a simulated E-chart and teach your patients that where exactly this problem is arising from. Doing the cosmetic ICL surgery doesn't stop there. We need to remember that we had done this surgery in a patient who had high myopia. So each follow-up visit should be followed up with a dilated detailed fundus evaluation, because the retinal detachment rate after phakic IOL is same as what it would be in a high myope. It doesn't alter it. So again, screening for peripheral degenerations has to be the same. Specular microscopy studies have shown that there is not much change in specular microscopy over long run, especially after introduction of the phakic IOLs with the central hole. However, some amount of change has been seen in the periphery, and those cases where a PI has been done, the peripheral changes in the endothelial morphology as well as the number quantitatively has decreased. One investigation which we do in our keratorefractive procedures, but probably miss out on our phakic IOL patient, is the biometry. A pre-op biometry is done, but this would be better to be repeated post-operatively as well, because certain cases where you operate ICLs at say early 20s, 21, 22, there are chances of axial myopia developing even after that. So rather than counseling the patient that or just answering them that the surgery is not working anymore, it would be easier if there is documented biometry report. So to summarize, it is best to do whatever investigations you have done pre-operatively. The same needs to be repeated post-operatively for the patient as well. Special emphasis needs to be given on the walt, angle assessment, lens changes, fundus evaluation, counseling the patient at each level. You don't need to have any of the fancy instruments to document this. Even a good slit lamp evaluation and giving a good chair time to the patient would be enough. So to end, I would like to invite you all for a cataract and refractive conference that we would be having in April in Bangalore. Please block your dates and visit us for the same. Thank you. If you have any questions for any of the speakers, we have time to take that.